Hi everyone, welcome to APAMSA White Coats and Rice's new series South Asian Health in Lens, or SAHIL, where we delve into critical topics in South Asian health ranging from advocacy to cultural competency with distinguished healthcare leaders. My name is Nikki Seth, first-year medical student and third year in the University of Missouri, Kansas City 6-year BA/MD program and the current vice president of UMKC APAMSA and member of the South Asian Committee here at National APAMSA, and I'll be your host for our Sahil series. For today's Sahil episode, we'll be speaking with Dr. Malathi Srinivasan, who is a clinical professor of medicine at Stanford University and associate director at the Stanford Center for Asian Healthcare Research and Education, also known as Stanford CARE, and also serves as director for the Stanford CARE Scholars Program and Stanford Implementation Sciences Fellowship. Dr. Srinivasan is active in the Stanford Humanities and Arts program and brings her skills as an educator, physician, health services researcher, and entrepreneur to shed light on crucial topics in Asian health. Let's welcome Dr. Srinivasan. Dr. Srinivasan, thank you so much for joining APAMSA and White Coats and Rice and for being our first guest on our South Asian Health in Lens series. Let's start off with talking a little bit about yourself and your journey and how it's led you to become the Associate Director of Stanford CARE Center for Asian Health Research and Education, also known as Stanford CARE.
Nikki, that's such a pleasure to be with you here today, and thank you to you, your audience, and to PAMSA for inviting me. I'm so excited to share with you a little bit about things having to do with South Asian health today. And if you had asked me when I was a young girl growing up in the Chicago suburbs, if one day I would be a clinical professor at Stanford working in South Asian health and in Asian health, I would have completely not believed you because, my parents, like many other people in the United States, who are Asian, had immigrated from India to Canada and then to the United States when I was a very young child. So I was actually born in Canada and I grew up in the Chicago suburbs. My brother was born when my dad was doing his postdoc at Notre Dame. And, we had a very interesting immigrant childhood in the sense that we had faced in this white collar, blue collar area that we grew up in a lot of overt discrimination when I was growing up. People hadn't seen a lot of people who were South Asian, and they didn't really have a good cultural basis. And there were a lot of prejudices that were held over about what it meant to be not white in America. And so when I was growing up, there was a lot of issues surrounding, being bullied because of ethnicity, being called dothead, and other types of things in a questioning and Midwestern environment. But at the same time, that was counterbalanced by a very rich expat and immigrant culture of all of our friends and families with whom we would interact. So the home life was very rich with culture and great foods and science and music and art at a very elevated level. And then the outside culture was a Midwestern area where we were, generally grossly misunderstood and in many cases actively discriminated against. My parents had been PhDs in Canada. My mom was a nuclear physicist and my dad was a radiation chemist. And so, our friends and family were sort of along those lines. And when I had gone to high school, my parents had dressed me up like a young South Asian girl, which meant like pigtails with ribbons in my hair, which you can imagine didn't go over particularly well when people were trying to be cool and trying to be styling. By the time I had gotten to college and was really finding my own voice at our state school, University of Illinois in Champaign-Urbana, I was really beginning to understand what it meant to have two identities. And being bicultural was a wonderful experience and also a scary experience because there was no navigation pathway. And at the time, there weren't that many Asians, and certainly South Asians, in the United States, 5.4 million people that we have right now. So I went to medical school at Northwestern and then did most of my training in the Midwest, including after my medicine residency, I did a 3-year research fellowship that was focused on health services research as well as on medical education and had joined the faculty at UC Davis. And there I was doing a lot of work around education, asking questions about how do you train a great doctor? How do you build programs that are going to help physicians and allied health professionals all around the world train clinicians better and make them more compassionate, make them better decision makers. And so my early work at UC Davis was focused both on medical education as well as on health services research, which is how we deliver care. And I was teaching internationally a lot with one of my colleagues, Dr. Michael Wilkes, who he and I would go to different countries and we would teach about capacity building around education and educational leadership. And then through my work in Asia, became much more interested, certainly in Asian health. And at the same time, as we were growing up, a lot of our family friends began having problems. They developed breast cancer, more so than I would say in other groups. They developed cardiometabolic disease. They started having heart attacks early. My grandfather died when he was around 60 of a heart attack, which, given how active he was and the fact that he was eating a very good South Indian diet, which we thought was terrific for him, but was very surprising. And so when I had moved in 2018 from UC Davis to Stanford and joined the faculty, there were a couple colleagues who have become fast friends who had started the Stanford Center for Asian Health Research and Education. And the goal of the center was to be able to improve the health of Asians everywhere. And you might say, well, that sounds pretty ambitious. And it is a very ambitious goal. And what we're trying to do is take aggregated Asian data within the United States and then disaggregate it so that we can actually understand what's happening with the health of Asians. Now, you might say that's, seems like a pretty much of a no-brainer, right? Asians are 60% of the globe. They're 6 to 7% of the US population right now. But they're only 0.17% of NIH funding, and this is with prior NIH funding. We're not quite sure what's going to happen with funding given priority changes now federally. But it's a very understudied group of individuals, and we know that there's differential health risks. So when I had joined Stanford and Dr. Lata Palaniappan and Dr. Bryant Lin had started Stanford CARE, I had joined to teach within a very small research program that they had started for undergraduates, and we grew that program up into the current CARE Scholars Program, where we're doing a lot of training around precision medicine for Asian health and training about 24 young people per year, and also doing work as a team with the Team Science Fellowship that we built to support the CARE Scholars Program. And so, the pathway, and at the time when I was growing up, there was no such thing as Asian health research. In fact, there was a lot of work around African American health and Latino health and LGBTQ health, Native American health, and minoritized populations that didn't really have a voice. But there wasn't so much about South Asian health. And or about other Asians comprising the big six: Chinese, South Asians, Filipinos, Koreans, Vietnamese, etc. And so we had, so the opportunity to be able to do work in this area was not there. And as a health services researcher who had training on understanding how to think about vulnerable populations, it was something I never thought I would be able to do. And it was really an honor to be part of the center and now to be associate director, one of the associate directors of the center.
It's truly inspiring to hear your story because I have a similar situation where I'm a daughter to Indian immigrants. I grew up in the Chicago suburbs, and to hear about the adversity that you faced while growing up in that situation and getting more and more involved in ways to bring more light to these issues and kind of the lack of awareness that Asian health trends are certainly prominent and should be addressed and cared for as many as the other minorities and other health trends. So I sincerely appreciate the work that you do. Just kind of leading into that, you recently led an insightful discussion on Asian health in America, and that delved into the model minority myth of Asians, and as well as differences and causes of death across several groups of Asians, as well as mental health. So, what have you found to be like common misconceptions about the South Asian community and South Asian health?
Well, I think we should start with what the model minority myth is and how it came to be. So, the model minority myth is this idea that one group of immigrants or a population is so much better than all the other groups. And in fact, that they're a model because they're so hardworking, they don't speak up, they put their heads down and are successful. And what that does is several things. Now, that sounds great. Sure, You are the model minority, everybody wants to be like you. But that's actually not true. But the model minority myth is used as a wedge to be able to set one group against the other. And by obscuring differences that are within a group, it actually leads to people ignoring important issues that happen for all of the people within the groups. For instance, the Asians generally, and Indians and Chinese people, Chinese groups in particular, are often held up as model minorities. If you are a South Asian, even though the South Asians generally may have a high overall income compared to other groups within the United States, there's about 10% of people who are below the federal poverty limit. If you are South Asian, 1 in 5 people, 20% of individuals have mental health concerns like depression or anxiety. And we don't even know the rates of schizophrenia or some of the other important psychiatric disorders. It means that people then are not asked about issues around their health or mental health or problems that are very important to the community. And because of this, they also don't seek help. And they don't, and there's stigma against being able to show your concerns, right? So in many Asian cultures, you're really taught that you have to present yourself in a certain way that is a very polished and together. But in essence, even if you are going through individual and personal struggles, because of the stigma associated with mental health disorders and with other health conditions, you may not actually seek help. And so that leads to things having to do with increased rates of depression, especially among older Asian adults who may have also language issues, with abuse and neglect or social isolation. There's not a lot of pathways for things having to do with intergenerational conflict. South Asian youth who are suicidal might actually not present by saying, "Oh, I'm depressed." They might just have academic difficulties or have risky behaviors or just have a stomach ache or a headache. And so the issues around being a model minority where everyone expects you to be perfect show up in lots of ways that actually are detriment to health and well-being of the entire group. So rather than personalized care and using a precision medicine approach, these stereotypes actually lead to these things that people may consider a positive stereotype actually lead to very negative consequences.
Yeah, absolutely. I think the model minority myth definitely needs to have more attention in how it can feed into negative thoughts and feelings and misconceptions around, especially Asian subgroups, where that may cause people to not feel like it's worth bringing up very important health problems. And like you said, a lot of research still has to be done on a lot of different trends like psychiatric disorders and other treatments that should be worked on to bring more light into what Asians may go through and their health trends. And yeah, those misconceptions are definitely some things that we want to tackle in the South Asian Health and Lens. So I do appreciate the work you do with Stanford CARE because I think it does help push us towards more knowledge, and that knowledge is something that we can utilize to bring a lot of advocacy to these problems. And with the work that you do, you recently published an article on the association of sleep duration and cardiovascular disease among Asian Americans, and it highlights how suboptimal sleep duration had a higher relevance of cardiovascular disease. So, in addition to sleep, what are some lifestyle choices South Asian Americans can consider to promote heart and metabolic health? Because, like you mentioned, it's pretty common in the family to hear of someone having either hypertension or diabetes. I know definitely people in my family suffer from it, and I'm sure it's a very common instance. So, to bring more light to this type of lifestyle, what are some different choices that South Asian Americans could consider so that they're able to promote those aspects of health?
Yeah, so I want to spend a moment on sleep. You probably know that the American Heart Association has recently, about 2 years ago, has adopted sleep as the eighth healthy lifestyle steps. Poor sleep and poor quality sleep is considered as bad a risk factor as smoking. And the other thing, of course, is that sitting is the new smoking also, because we know that exercise dramatically changes your cardiometabolic risks. South Asians have about twice the heart disease risk and about twice to 2.5 times the diabetes risk as someone who is non-Hispanic white. And you might say, well, why is that? Like, what's different about us? And if you can imagine, India over, say, the last 10,000 years has gone through periods of feast and famine, of low water resource, of time where there was a lot of food scarcity. And the same way that in Africa, if you had specific mutations that made you less likely to die of malaria, namely having sickle cell disease, with oxidative stress, these cells become sickles, and then it'll kill a parasite also. There was a survival advantage to being able to someone who stored fat and who was able to not and be because fat is a food storage that lets you release sugar when there's no food. Okay. So what has become a survival advantage in times of food scarcity is now a survival disadvantages when you come to longevity. So the that paradox is really important. And one of the things that you'll notice is that there's also something called the obesity paradox, where you have people who are actually normal weight, and if you look at them, they look just like a normal healthy person, but in fact, they are metabolically unhealthy and they are metabolically obese. And because South Asians in particular store fat around their organs, and it's called visceral fat, and for the same body mass are going to have less muscle. We actually have much higher rates of heart disease and diabetes. And in fact, it's that combination of cardiometabolic health where you have fat deposition in your liver, around your organs, you don't build as much muscle, and muscle, believe it or not, is actually a major component of your metabolic health. And because South Asians don't build as much muscle, and most Asians don't, in comparison to non-Hispanic white, and you build muscle really until your 30s and kind of your 40s, and then it's harder to keep, and then you start to lose it after that. You can actually having low muscle mass later on in life is one of the biggest predictors of whether or not you age healthily and whether or not you're going to die, because people have falls, they are unable to, they get hip fractures. And so this combination, and also muscle uses glucose independently of insulin. And so if you have someone who's unable to process and store sugar in the most healthy way, if you can actually reduce your blood sugar by having more muscle, you do better. Okay, so there was a study called Masala that was published in 2010, which is the mediation of atherosclerosis in South Asians living in America, that had really shown the higher incidences of cardiometabolic disease in Indians. And so, in fact, it's so bad that the World Health Organization and the Indian Ministry of Health have reclassified what it means to have a healthy weight for people who are Asian. And if you are Asian, whereas the body mass index, which is a measure of how tall you are compared to how much you weigh, if you take a look at that, the body mass index of 25 is considered the upper limits of normal for someone who's Caucasian or Hispanic or African American, but it's actually 1.5 points lower for people who are South Asian and Asian. So at every point in time, whether you're thinking of obesity at a BMI of 30 or morbid obesity at a BMI of 40, because of our differences in cardiometabolic health, the numbers are 1.5 less. So it's really important for us to have an understanding of the foundations of this, and also understand that there's pharmacogenomic differences that are also driving how we treat these issues.
So, Dr. Srinivasan, could you delve into the pharmacogenomics? Because I think that's also a really critical topic to kind of delve into to provide more context on that foundation.
Right. So in every country where people have lived for tens of thousands of years in a specific location, there will be variations from what's studied. I want to make 2 points. The first one is that Asians in general, and South Asians in particular, do not participate in very many research trials. So if you take a look at the number of people who are Asian in the world, it's about 60%. The number of people who are participating in clinical trials is about 10%. So all of the decisions that are made about Asian health are for the most part done with non-Asian data. Okay, so it's even worse when it comes to genomics. So there was a study in 2016 of that was a meta-analysis of about 2,500 studies that looked at genomic data for 35 million people, so including people from China. Only 19% of all of the genomic data is done on Asians. So what that means is that you have omission, aggregation, and extrapolation of data from other populations to the Asian population. And what does that mean for South Asians? Well, we know a lot of stuff, right? So already what we do know is that let's just kind of stay on cardiovascular issues since we've been talking about that. If you take a look at things like metabolism of drugs for treating heart disease and heart attacks, or someone who's had a stent, you might use a medication called Plavix, which is, the generic is clopidogrel. And if you're Asian, South Asian, you are more likely to bleed if you're given Plavix. And why is that? It's because you have something called a gain of function mutation. And what that means is that a particular enzyme, and without getting too technical, the enzyme name for those of you, since there's a pre-medical audience here who might care, is CYP2C19 star 17. Okay, I know that's a mouthful, but that gain of function mutation takes clopidogrel, which is a prodrug, and translates it into its active form. And because that enzyme system in the liver is more active, you make more of it. So you're going to be more likely to bleed because it's an anticoagulant, right? So if you have a medication that we use for atrial fibrillation called warfarin, you actually need to have less of a dose because you're going to be more likely to bleed because there's an enzyme system called VCORC1, which is different in Asian Americans and in South Asians. And you should be giving someone a different dose than you would because you're going to be more likely to bleed. So if you look at statins, which we use to be able to treat high cholesterol, then you also it's important to know that statins aren't metabolized as well it's important to know that statins aren't metabolized as well for people who are South Asian. And in fact, you need less of it because you might actually have more side effects. So for people who are South Asian, for all of you budding cardiologists out there, if you have a South Asian patient, start at a lower dose and then ramp up slowly and monitor for side effects. And if you start getting side effects, back off on the dose and you can add second and third drugs like Zetia or the PCSK9 inhibitors. But it's important to kind of think about these differences. And that's the first point. So the second point is that in many cases, we actually don't even know why we're having differential outcomes. Breast cancer rates are increasing significantly in South Asian women. And when you do genomic profiling against the things that we know are hereditary breast cancers for people who are Caucasian, like the BCARA1 and 2 genes, they may not have those. But when they do whole genome sequencing, we have things that are in that same area, which people are calling variations of unknown significance, right? So there are variations that may be very common in South Asians, but we actually don't know what they mean because they haven't been studied. So it's very important for people who are South Asian and people who are Asian in general to join clinical trials so that we contribute their genomic data so we can begin to understand what's happening in our populations.
Yeah, definitely. And learning more about the foundation of why these trends are what they are, rather than just knowing that they exist, I think is crucial, especially for aspiring physicians, so that they can gain more perspective and kind of awareness from that pharmacogenomics, or pharmacogenomics, excuse me, just so that they have more understanding going into it when they treat these patients. I think what you said about statins also resonated with me a lot because it's such a common form of treatment, but something as simple as a statin, you have to consider the nuances when you have a South Asian patient because it may not present the exact same way. They may have more side effects, and so the dosage has to be adjusted accordingly. So that is really important to know. So I appreciate you mentioning that. And with those lifestyle choices as well, is so knowing that foundation is really helpful. So with the building muscle might also help. So I know oftentimes we just say that exercise is great because maybe with diabetes that tends to be the trend if they're more obese, but when it comes to Asians and South Asians, that's not always the case. They may be a smaller frame but still have diabetes just because of those environmental aspects and the genomics. And so things like maybe building muscle might be helpful to consider in addition to what they may consider as other exercise like walking and simpler exercises like that. So it's good to know that maybe building muscle is another thing to keep in mind for those lifestyle choices.
Nikita, you're so correct. And in fact, Dr. Palaniappan had done a study called Strong D. So it was a strength training versus cardiovascular training program to take a look at what happened to people with diabetes. And in fact, strength training for South Asians was more important than cardiovascular exercise to address diabetes. And I think it's in large part because of the visceral fat issue and then the building of muscle issues with sarcopenia that we talked about. There's a lot of other things that people can do also to be able to improve their sleep. And some of it is the standard advice that you're going to get. So, make sure you're paying attention to your sleep. Don't smoke. Ideally, we used to think that some amount of alcohol was safe in terms of long-term health, but we know now that really, all alcohol is bad alcohol for your health. And so if you're going to drink, just make sure that you're being very moderate and use it as something that's occasional, not every day. We could talk a lot more about diet and fats too. I know a lot of people are always asking me about what cooking oils to use and how to think about their food choices.
Yes, that would be a great thing to touch upon because it is something that's quite common with cooking. At least from my perspective, I would hear from family members or family friends that the amount of cooking oil is playing a big role, but they don't really know how to adjust things. They've just kind of heard a lot of bits and pieces here and there, but don't know what to do with it to help improve their health. So definitely talking about that would be wonderful.
Great. So Indians and Asians love to eat. And in fact, I don't know about you, Nikita, but my fondest memories are of our family gatherings and everyone, cooking together and eating together. And in fact, much of our conversation would usually center on what we had eaten, what we were eating, and what we were going to eat. And the deliciousness of the foods is unsurpassed, I think, amongst all of the Asian groups. And of course, I'm very biased, but if I could have my mom's gulab jamun every day, I'd be very, very happy. So, what does that mean for our health, though? So, knowing what we know about cardiometabolic health in South Asians, the things that we have to know about are sugars and fats, right? So, we have our energy comes from either carbohydrates, which can be simple complex or fibers, proteins, and then also from fats. And so I'm going to touch briefly on all three of these. So let's kind of talk about the protein issue. So for people who are vegetarian, which many South Asians are, finding adequate protein is a little challenging. And you have to be pretty meticulous about making sure that you're having balanced protein so that the essential amino acids that you need come from both legumes as well as from grains. And when you're choosing grains, you want to choose more complex carbohydrates, which take a little bit longer for your body to digest and metabolize into sugar. So for proteins, the general recommendation is that you want between zero point 0.8 to say maybe 2 grams of protein per kilogram. It depends on how much you weigh. And I would encourage all of the APAMSA students who are listening to this podcast to really go out and take a look at food labels because I think that getting familiar with food labels is very important. So every plant or food group has all of the essential amino acids. It's just the proportions of them and having them available to you in a way that's useful, that's important. And so if you're a vegetarian and you have either eggs or milk products, it becomes much easier because there's both protein supplements that you can take, as well as, dals and, as well as eggs and milk that are available to you that have complete proteins. But if you're vegan, then you have to be a lot more careful with your protein intake. So, just please become a little bit more educated about that and then read your food labels and think about how you can get the right amount of protein. And it should be about 30 grams per meal, usually less than about 20 grams per meal. The protein is not necessarily going into building muscle. It's often just used and or stored as fat. So we don't have a form of protein storage. We only have a form of carbohydrate storage, and carbohydrates, of course, are stored as fat. And so all the excess protein that you eat, if you eat a lot in a meal, is just going to get converted to fat if you're not going to be using it right away. So the carbohydrates, as I'd mentioned, come as simple, which are just things like sugar, like glucose, fructose, and other simple sugars, or things that are more complex carbohydrates that are longer chain sugars, and then things that are fibers, which are really fairly either soluble or insoluble. And the insoluble fibers are the soluble fibers are the ones that are used by bacteria to be able to support your metabolism in your GI tract. And the what's important about carbohydrates is carbohydrates are metabolized, are digested by your so carbohydrates are digested by your stomach and by some of the enzymes in your intestine, and then they're absorbed. And when you think about people who have diabetes, the rate at which those sugars are absorbed into your blood system in the intestines, and the baseline amount of blood sugar, of sugar that you're making from your liver, are the two things that determine your blood sugar level. Okay. So when you're eating, what you want to do is try to reduce the spike by slowing down digestion. And that can be done by several things, by having fats and complex carbohydrates like, salads and things at the beginning of your meal. So a salad with a really good salad dressing, having a vinegar, which will slow down about 2 tablespoons or so, which will slow down your gastric emptying. So again, going back to that really great salad at the beginning of the meal, and then having more complex carbohydrates, which your body has to work harder to digest. And so a carrot that is baked has a different glycemic index, which is kind of a rate of, if you have 100 grams of carbohydrates, how fast does your blood sugar rise? An hour or so. The type of food and the food composition becomes very important, and the order in which you eat also becomes important. So understanding that about carbohydrates, that you can actually choose things that are lower glycemic index, meaning how fast the sugar is absorbed and how much your blood sugar spikes when you have that type of food, right? So a glycemic index of 100 is if you have like 100 grams or so of glucose and what happens to your blood sugar. But a baked potato has a glycemic index of 110, whereas say broccoli is going to have a glycemic index of maybe 20. So in general, we want to try to keep most of our foods having a glycemic index of less than 55. And then when it comes to things having to do with fats, there's a lot of misconceptions about dietary fats. In our blood, the good cholesterol is called HDL, and the bad cholesterol is called LDL. South Asians also have a higher incidence of a very bad type of lipoprotein called lipoprotein A. And if you don't know if you or your family have it, you should get checked out. And the things that drive up the bad cholesterol, the LDL, are saturated fats and transaturated fats. So any fat that is solid at room temperature in general is saturated, and anything that's not don't that is better for you. So things like the seed oils are actually not that bad for you. And there's a lot of villainization of individual food groups that comes from a lot of food misinformation. And the seed oils in general are just fine, even if they are refined at a slightly higher temperature. When you cook, you're also cooking at a slightly higher temperature. So things that we love that make our food really, really tasty, like ghee, clarified butter, or a coconut oil, are actually really bad for your health. They will drive up your bad cholesterol, and they'll drive up your good cholesterol, the HDL, a little bit too. But it's not in general good for you, and it will drive atherosclerosis. So any cardiologist and preventive cardiologist will tell you, if you're going to use them in very small proportions, and use the better oils. Use the ones that are liquid at room temperature. Things like olive oil or a canola oil, which is from rapeseed, or avocado oil or sesame oil. In Tamil, we would call that nallana, the good oil. And so those are generally very good to use. And then you got to think about whether or not they can take heat or not. So the high heat oils are things like sesame or peanut or avocado oil. And the things that are not high oils or the low heat oils are things like olive oil. So those have a low smoking pressure, those have a low smoke point and shouldn't be used because charred food is also carcinogenic. So anything that is charred, you are eating pre-cancer or you're eating things that can promote cancer because there's a lot of very reactive components in those, and they're difficult to metabolize. Then you have to release, your body has to spend a lot of time detoxifying it. So just like microplastics, charred food is bad for you. So, a lot of our tandoori foods or other things, the things that are very tasty often have some charring. So whenever you can, please remove it. And if you're going to do it, again, just have it in small proportions. The other food misconception that's very common in people who are eating Indian diets is about dals. They say, oh, dal is a protein. No, dal is like maybe a third protein and two-thirds carbohydrate. So if you start just having only dal, not only will you have an unbalanced amount of carbohydrates, excuse me, not only will you have an unbalanced amount of your essential amino acids that you need to build your protein in your body, but you also are getting a lot of carbs. So they're generally better carbs for you than eating a jalebi, but they are because again of the fiber content of the dals, which slows down digestion also. But you have to kind of understand how your body's reacting to these things. So those are the big food categories. Oh, the other food myth is that peanuts are protein sources. Peanuts are 80% fat. So any nut that you have is going to be about 80% fat. So although there is some protein in it, it is mainly fat. So as you are thinking about the foods that you should eat, it's very difficult with a standard South Asian diet to be able to get the nutrition you want. And you have to start incorporating more salads into your food. And then you have to change the order of the food that you're having. And if you're going to have jalebis or other types of, yummy Indian desserts for my mom's gulab jamun, then you want to have it in a small proportion at the end of your meal. Do you have any?
That is extremely helpful. Thank you. Because I think we often hear, like I mentioned before, those bits and pieces of like fat is bad for you, but we have to understand there's good and there's bad and how necessary fat and other like carbs, proteins, the roles they play in our metabolism. Understanding how we can adjust smaller things in our diet, like the order of the foods we eat or the amount of them, or like how you mentioned, like for example, I love tandoori foods a lot, but to keep in mind to maybe remove that charring part of it. So small adjustments without changing too much in our everyday diet can make a big difference as long as we gain that education of what can be potentially dangerous to our health versus what we can keep the same or rearrange just to make things a little bit more healthier for our heart and metabolic health. So that's definitely very helpful.
And it's very hard to have a standard South Asian diet if you're vegetarian. And um, uh, with our genomic and our metabolic profile, to actually not store fat. And so it takes a lot of work, and you really have to make a lot of adjustments to the foods that you take, the order of the foods, have more vegetables, have more subgies, and then not be afraid. There was a villainization of fat back in the 80s, 90s, and early 2000s. But fat is not a bad thing. It's an essential food group that we need to for brain health and for everything else. It just has to be the right ones in the right proportion. And then there's, of course, things where you have to know your own personal risks. And we can talk about that a little later.
Yeah, for sure. And like how you mentioned the risk profiles, I actually wanted to ask further about it because based on your in-depth experience with Asian trends and ranging from cardiovascular disease to mental health, are there any particular screening guidelines that you think should be adjusted for South Asian populations given their unique risk profiles?
Yeah, I would say there's three. The first one is that we talked about the body mass index, and it's not the best measure of obesity, but there's some roundness indexes that are better. But know that the BMI value for South Asians and for all Asians is 1.5 less than non-Hispanic whites and other groups. The second one is for South Asians in particular, get your lipoprotein A check to see if you are at high risk for early accelerated heart disease. I think that everybody who's South Asian has known someone who's had a heart attack or died early of a heart attack, or even, famous celebrities like Rajiv Kapoor, who died at 58 of a heart attack despite having no known pre-existing health disease, or, the cricketer Mulnav Patel, who had his first two heart attacks at 39. So see if you're at higher risk to have heart disease and a heart attack early. Then the LDL targets, the bad cholesterol targets, should be for any South Asian, should really be less than 100. Okay. If you want to get regression of plaque, if you have it already, your LDL has to be less than 60, ideally in the 50 range. So 40s or 50s. And we know now from the ischemia trials that no LDL level is too low. Then from a diabetes perspective, try to make sure that your hemoglobin A1C is in the normal level. And please, please, everybody, if you are over 30, at least once a year, get one of the over-the-counter continuous glucose monitors. And the Freestyle Libre 3 from Abbott right now is the smallest profile and easiest to use, and you can get them over the counter these days. It's a little spendy, but just at least once a year, see how you're responding to food. Try to keep your hemoglobin A1C, which is a 3-month look at your blood sugar, in the normal range, and make sure that your fasting is less than 100, or ideally less than 105, and that you know how you're responding to the normal amounts of food that you take. And if you're not sure what to do, then keep the glucose monitor in for a couple months and adjust your food and your exercise patterns to see how you're going to do.
That is extremely helpful. Thank you. Yeah, I think it's really important to kind of give some guidelines for people to work off of to know what they may need to keep an eye out for, and whether they came in having some idea of that, maybe I should check my glucose, or if they came in with no idea that I'm South Asian, but I have no idea what potential risks I could have. That's extremely useful for them to refer back to it and say that, hey, maybe I should check the lipo A or my glucose levels based on my diet, so that people can be more aware about their potential risks being South Asian. And when it comes to South Asian patients, how can non-South Asian healthcare providers build more trust and rapport effectively with South Asian patients?
Cultural competency has to do with being able to provide clinical information and a pathway towards health and disease treatment that recognizes the specific values and beliefs and attitudes of a group. And there are some general things that people need to do to be kind and open and to listen and ask questions. And then the a second issue is to actually have data so that you understand individual people's health risks. So that can be done through looking at different websites when you have people come in to for a health examination based on where they were from or where they grew up, or any particular religious or cultural beliefs that they might have, or groups that they're part of. And it can also be done through education. Stanford Medicine has recently invited Stanford CARE to help integrate Asian health education into all 4 years of the medical school. And as far as we know right now, it's one of the few places in the country that's actually doing this systematically. So we're just in the beginning processes of developing the toolkit for educators to incorporate Asian health and South Asian health into all 4 years of a medical curriculum. Eventually, we hope to work with point of care delivery companies like Epic, or educational point of care services like Up to Date, to be able to have Asian and South Asian specific health modules that will be plugins to what people are already doing. So if you have someone who comes up to you who is South Asian, and you're using a particular tool, you might have a pop-up that says, make sure that you ask about these 5 things or consider these 5 things. So those are longer term things. But I think in the short term, I think asking questions, inquiring about issues having to do with mental health, with school, with education, with people's lifestyle and activities is very important. So a lot of the standard things that you would do, but being respectful of the fact that Asians tend to live more in multi-generational households, that they may be bicultural, that they may have people in their family with low health literacy, or who may be speaking additional languages. Making the environment very welcoming would be very important.
Yeah, I completely agree. And I think how you said, it's pretty much the simple things like making them comfortable and being patient with them as you would with any other patient that you would have. But considering things like, I agree that multi-generational household is a big one, and also language barriers. And India in particular, when we talk about South Asian subcontinent, but India has so many languages in it that sometimes you never know what language the patient may be speaking. At first, you may think that, yes, they're Indian, but doesn't necessarily mean that they're speaking Hindi or this language and that language. So being prepared maybe for an interpreter, or just being patient with them in case it's a little bit more frightening, especially maybe if it's an older adult South Asian patient who is not maybe very fluent in English. They may feel a little bit nervous at first to open up about their health problems when there's already a language barrier. So definitely being more understanding and actively listening to them in whatever way you can is probably very helpful in building that trust with South Asian patients.
It is, and it's important to differentiate those things that are general skills versus those things that are specific skills. And I think that, when we think about Asians in America, people nowadays think of people like Satya Nadella, who runs Microsoft, or Leela Nair, who runs Chanel. But then you also have, as you've mentioned, the people who are immigrants, your grandparents, or sometimes even your parents, who have a very different cultural framework and may not have had the same advantages of some of the people who are in these positions of power. So I'm glad that we're having this conversation about how to treat each person as an individual and tailor conversations so that you can help everyone reach the best health outcome.
Absolutely. And I know also culturally, sometimes in Asian culture, it may be custom to just kind of let the doctor do their own thing, not really ask any questions, which may also feed into the lack of understanding that we have behind certain health trends. So maybe being a physician in America, when you have South Asian patients, just kind of showing them that it's okay to ask questions if you are curious and being very open to explaining things to them so that they're more aware, and that'll also allow them to maybe adjust things in their lifestyle or be more open to treatment options and establish that comfort level that there's a trust in asking me things. You don't have to just assume that I am like higher up and that you can't ask me anything.
I completely agree with that. I think that especially for people from other countries who don't have either the language skills or the same cultural framework and who are used to a more authoritative method of practicing medicine, it's very difficult for them to speak up or even know what to ask. So in medicine, we use a method called teach back, where you give someone some information and then you ask them to summarize what they heard from you. Because what I've often found with a lot of people, especially Asians who may not understand exactly what you're saying, they're scared to ask questions or they feel uncomfortable asking questions about what they understood or didn't understand.
Yeah, for sure. I think the teach back method is definitely very helpful in terms of kind of understanding that what the patient is receiving from all of this. Because sometimes if a doctor is talking about many different things, especially if you're first diagnosed with something, it can be very daunting. So at some point, as the doctor speaking, it may all just sound like a bunch of words coming at you, whether you're a South Asian patient or not. I'm sure that's a pretty universal experience. In general, that teach back method is helpful to kind of bring the patient back to the conversation, involve them more, and also gives the physician an advantage in understanding where the patient is coming from and how to meet them where they're at and work from there.
Exactly.
Yeah, and so when it comes to, like you mentioned, that Stanford is very involved in integrating Asian education into the curriculum, as well as with Stanford CARE already doing so much to bring more awareness and understanding those health trends and the reasonings behind them. So, how can students and professionals get involved in research to promote awareness of Asian health through Stanford?
We're so lucky, Nikita, because Stanford has over 100 faculty who are doing research in Asian health, not just in South Asian health, but in Asian health overall. We have departments of Asian studies and all kinds of other programs that support the really good work that Stanford's doing, leveraging our precision medicine and approach to being able to personalize care along with all of our AI stuff that we're doing. There are so many opportunities, and I want to just highlight two of them. I'd mentioned earlier that in 2019, Doctors Palanithan and Brian had started a small 5-person summer program around Asian health research. And we've expanded that program to now 24 students from around the world. And we teach people how to do thoughtful precision medicine using large national databases so that we can ask and answer foundational questions about the state of Asian health in America. And so the program is called Care Scholars. We'll be opening applications soon, and I would really invite anyone who's interested in personalized medicine and learning how to ask and answer good research questions to participate in this virtual year-long program. It's phenomenal. And I'm not just saying that because I'm program director, because we've built this program with a lot of love and attention, not just to research skills, but really to personal growth and development. So it's a great way to enter this field. And of course, it's competitive like all of the other Stanford programs, but we're really looking for people who are passionate about Asian health and who want to make a difference in the world and understand that data is power. And being able to tell good scientific stories is really critical to being able to have good public policy. The second is for people who are already in their master's or doctoral or postdoctoral work who are also looking for a part-time virtual program to help learn how to run a dry lab. We have the Stanford CARE Team Science Fellowship, where we take about 6 of these graduate students and then have them help teach within the Stanford CARE and CARE Scholars environment. So people get great mentorship. They work directly with a lot of Stanford faculty and learn how to manage a dry lab. So we're really excited by these opportunities. There's also opportunities to participate in people's research programs. And I would really encourage anyone who's interested to contact either me or contact people within our center.
Yeah, it sounds like a great opportunity, no matter where you are in your journey as a student or a master's student and so on, to be able to partake in, like how you said, data is so critical and just a piece of the process of understanding trends and then the reasoning behind it. And then for us as aspiring physicians, how to apply that to patient encounters to provide them the best care that you can. And so I think these are wonderful opportunities that people should definitely get involved in if they want to kind of contribute to that breadth of knowledge. So that is certainly amazing. So thank you for mentioning about that. And so as we wrap up the episode, I do appreciate you discussing so many critical things from nutrition to the pharmacogenomics and preventative health lifestyle. So many critical things that people of all backgrounds, whether it's medical students, pre-health, or anyone else just tuning in. Circling back to your experiences, so looking back on your experiences as a South Asian medical student, what advice would you give to current South Asian medical students as they navigate this period of their lives?
I think that when I was a young medical student, I really didn't know myself very well, and I didn't have a sense of as much purpose and direction as I do now. And the process of developing from a student into an adult with a profession is a long and arduous one, and it's a journey of self-discovery and introspection on top of all the hard work and the other opportunities that you get. So my advice to people, I think, would be several things. The first one is to be open to finding your dharma. Dharma, I think, is your sense of meaning and duty. It's the purpose that you bring to your life and the passion that you use to be able to make a difference in the world. And so it'll come to you as you gain more experiences. The second is don't be afraid of trying new things. When you are young, you should be saying yes to a lot of things because you never know what's going to really appeal to your values and appeal to you as a person. And the journey that you'll take will be different than the journey that anybody else will take. The third thing I would say is please find mentorship. You don't need to do this alone. The path that you will tread for yourself will be unique, but the frameworks that you will use to do it can be cultivated. And your mentors will not only open doors for you, but they will guide you and be sounding boards for you as you continue your life journey. So, I never thought I would be in this field. It didn't really exist at the time I was in medical school. And the types of fields that you will all be involved in are very different than the ones that will be involved in. Hopefully, you'll be also asking and answering questions that are important to you. But really, just prepare yourself to be able to make a difference and be a change agent and be open to your dharma.
That is extremely comforting to hear from someone who has gone through so much and experienced so much and has the role you have in being able to contribute to such a critical program and Asian health overall and bringing light to so many important things, both for South Asians, like the point of South Asian Health and Lens is to provide more insight into the why behind different trends and how we can adjust things in our lifestyle. So both a South Asian audience, but also just anyone who wants to gain more understanding of these things. But I do appreciate, as a South Asian medical student myself, hearing more about that, and the finding your dharma is extremely comforting. So I do really appreciate that. And how you talk about mentorship, do you have any strategies that you recommend to South Asian medical students for finding supportive mentors?
There's two types of mentors. There's a mentorship that is general in terms of career navigation and going to all of the APAMSA meetings and then going to various other groups that can help provide you with understanding the system in which you're working is very important. So how do all of what are the career options that are open to you, whether it's in journalism or podcasting, or if it's going to be in as a business person, an innovator, entrepreneur, or you pick your field. How does medicine, which is a platform, intersect with those other fields? Because again, medicine is both a profession and a platform. The second thing I think in terms of finding personal mentorship has to do with your interests. When I was a resident and a fellow, I was lucky enough to be in a really wonderful research fellowship. And during that time, I was also doing a lot of sort of national medical things with the American College of Physicians and then with National Consortium of Residents and other groups, ACGME. And so for each of my passions and interests, I tried to find at least one mentor who was willing to take me on. And what I would do is I would just ask people who I admired and who I thought I would get along with. And sometimes they would say yes, and sometimes they would say no. And when you're asking someone to be a mentor for you, you should be really specific about what you're asking for. Are you asking them for just to be a sounding board and to meet with you periodically, to work on a research project with them, and just be cognizant of the fact that everybody is very busy, including you, but your mentors are usually going to be busier than you are. And make sure that you're respectful of their time when you come in with a well-prepared agenda when you're meeting with them, and then try to send it to them in advance so they know what to expect. So I think that finding mentorship is, in most cases, as easy as asking, but you have to ask with the right intent and with the limited amount of things that you would like to do with them when you're first getting started.
Yeah, that definitely makes a lot of sense. And what I gathered from that is when it comes to looking for mentors, you should be brave so that you're open to asking someone that you think will be a good fit, whether it's for research or for career advice in general. So being brave, being curious. So especially when it comes to research, the root of research, at least to me, is curiosity and like a sense of commitment to gaining more understanding of crucial topics. So brave, curious, and then being intentional, like you mentioned. So to respect their time and being very clear on what you hope to gain from these interactions so that you're able to grow as a student, but they're also gaining a lot of insight from being such an important mentor to many people, I'm sure, through the work that they do. Bravery, curiosity, being intentional, I think are definitely really important.
Well said. Your mentors will get as much from their interactions with you as you will get from your interactions with them. People agree to mentorship because they love students and they love learning. And as someone who's been lucky enough to be the recipient of amazing mentorship, part of our duty is to give back.
And we certainly appreciate what mentors do because, like how you mentioned, it's their own sense of wanting to guide people so that they're also able to contribute in the same ways that mentors do because there's a shared interest probably in several topics. So mentors certainly shape the next generation of, in our case, physicians. And so they're definitely needed for everyone to be able to develop and become more culturally competent physicians or more understanding of different trends. So it's definitely essential. And guiding into our next part, we are introducing a new segment into our White Coats and Rice podcast. And it's where we have an audience member send in questions through a podcast form that's on our White Coats and Rice podcast website. And so audience member Neha asks, did you reach out to or rely on professors from medical school during your residency?
So I think I wish I could ask Neha a follow-up question, meaning what does she actually mean by this? Because I think that it depends on what you're reaching out for. So when you are in your residency, you are surrounded by new experiences and increasing responsibility. And I think that the people who have agreed to be your mentors, especially if they are career mentors or research mentors, will be always happy to have someone call them with questions. Anytime you're developing your mentor panel, it's good to have people within your institution and people outside your institution. There are sometimes things that are sensitive topics that may not be appropriate to discuss in your own institution as opposed to how to navigate or the people that you might have may be part of your program leaders and your faculty may be actually the ones that you are having an issue with or a question that you might have about. And so having someone who's outside of your institution to bounce questions off of is very, very smart. And you can build both those formal and informal networks that will be comprised of people who you trust and who trust you. So I think that when you're going through and developing your lifelong mentors and your project mentors, be cognizant of what you're going to need them for over time and think strategically about who you should be going to for different pieces of advice. I'm assuming that within Neha's question is not the how do I take care of this particular patient? Usually the patient-oriented things are going to be pretty straightforward and you can figure that out within your institution. I'm assuming that what Neha means is how do I navigate difficult situations within my program? And that may not be appropriate to talk to within the program. So for those, I would definitely recommend people who are outside of your institution.
Yeah, that's very helpful to keep in mind that sometimes having mentors both in and out of the institution can be a good resource that can be more tailored to what you want to discuss or talk about, whether it's something that's more applicable to the institution's program versus something that's more personal and career oriented. So I definitely agree about that. All right, so thank you so much, Dr. Srinivasan. That was everything that we wanted to cover. And so thank you so much for taking the time to discuss so many critical topics. I think it's so important for people of any background to learn more about South Asian health and how nuanced it can be when it comes to the different health trends we see. But I really appreciate how you touched upon the why behind some of them and like how our culture and our environment, both in the Indian subcontinent and South Asia in general, to being immigrants, how different things can kind of factor in to what we see on paper and how some things we've yet to discover and different trends that we're still working towards and why the research is so important. So thank you so much for taking the time today. I really appreciate it.
Thank you, Nikita, and thank you to APAMSA and to your audience for letting me share some of these ideas. It's really been an honor to be with you.
To our listeners, we hope you enjoyed today's episode and learned more about the beauty and nuance that is South Asian health in America. Don't forget to tune into the rest of our series, and until next time, take care. Thank you.